So, current diagnosis of back pain, sciatica. We're going to stay just with the lumbar spine today. Our diagnostic techniques, our philosophies, our thoughts about back pain, they all come from, or are derived from, studies of inert anatomy and inert MRI scans and the treatment of patients while they're anesthetized. And I'm going to be very provocative and tell you that this has led to a number of ill-founded concepts. And I believe that the answer really lies in more secure diagnosis derived from patient feedback and aware state surgery. So we're coming at the patient not from behind the patient or through their tummy, but transforaminally. Now, this is a fairly new little video, and it did start out a week ago like Star Wars, and I wish the procedure was quite as simple as this, but we are using a laser to cut away the scarring and the bone and ligaments that are trapping the exiting nerve route through the foramen. And that last ligament is the superior foraminal ligament, which cannot be accessed easily from midline approaches. And therefore, midline approaches tend to under-treat the problem at a foramen. And this is what you see when you get in there. It looks even worse on that screen than in real life. But the nerve is there, if I can get it to work. Ah, okay. So the nerve is actually there and there, covered by scarring, and believe me, the facet joint is there, and the other facet and pedicle is here. And after quite a little time, we've excavated the area, removed the scarring, you begin to see the bone here of the facet joint, and this is the beautiful nerve, still covered to some extent by the superior foraminal ligament, but now the protection of epidural fat is coming through from the epidural space in patients who haven't had previous surgery, that is, to continue to protect the nerve. And this, of course, is the dorsal root ganglion. It's just, the nerve is just beginning to swell into that. Having worked some time in France, we tend to christen this ligament as Madame la Guillotine, because as you lose disc height, of course, that ligament starts to impinge further onto the nerve and cause irritation, and is often found bound to the nerve. So when you've done an effective clearance, maybe getting some color bleeding here today, here's the epidural fat coming through, here's the nerve. Now the nerve should be a pale color similar to the walls of this room. Here, after the constant irritation, you will see that it's very inflamed and red. And just to show the brutality that I get up to in my spare time, here, this is the nerve running across here with its lovely little vessel on the top. I've spent some time clearing away the scarring on the top. Here's the superior foraminal ligament. But what that's showing is that the disc, which we've stained blue, is very soft and protruding, and that the nerve was adherent to that billowing disc. And if you leave it like that, you're going to have ongoing symptoms. So what have we learnt from patients over the last 25 years? That back pain, surprisingly, comes from the nerve. I think we've all grown up believing that back pain actually comes from the disc. Well, when we were touching that nerve, the patient was complaining of back pain. If you press more firmly onto the nerve, then you'll produce pain that radiates down the leg. But not always in the territories that we were learning about in medical school. There seems to be a lot of crossover. For instance, I can produce S1 nerve symptoms at the L4-5 level. And equally, I can produce so-called sacroiliac joint pain by touching the L3-4 level, or L5-S1, or sometimes L4-5. So, yes, you can get physical compression of the nerve, and that will produce neurological dysfunction, but the disc may produce irritative breakdown products which inflame the nerve and produce symptoms which are further enhanced by several methods of impaction in that foramen. And all of it's magnified or amplified by foraminal tethering. Then there is true discogenic pain. Sometimes you touch the disc and it's highly inflamed. You can see that there are injected vessels, there's angiogenesis in the wall of the disc. But in our patients, it's only about 11% of them can you reproduce that. I think you're all thinking about, oh, discography. Discography causes pain. That's surely the cause by the disc. No, discography distorts the disc and then presses on the nerve and then causes your nerve-derived pain. So high-intensity zones, which are dismissed, I'm afraid, by a lot of colleagues, are a source of very severe pain sometimes because the breakdown products are very noxious. Then there's another group in which the breakdown products actually produce scarring. And then there's another group in which they get both, unfortunately, the scarring and the pain. But thankfully, there's a small group where the high-intensity zone doesn't cause any pain, probably because they're not making the right sort of horrible products. And again, those products coming out produce the tethering. And the tethering is further aggravated by the loss of disc height and repetitive microtrauma onto the nerve. And that leads us into so-called instability, instability in the spine. I think most of us here have had kids. We all know about building blocks. That's instability when the little kid knocks over a bunch of blocks. Here, you've got lots of ligaments and facet joints keeping the spine in some form of alignment. If you lose disc height, you then get, if you like, a soggy disc. You get abnormal micromovements, and then that brings the facet joint into conjunction with the nerve, producing pain. And so instability is actually that catch symptom. As your patient gets up to leave the surgery, oh, they catch in front of you, and you think, poor thing. And what's happening is that facet joint is just catching onto the nerve. And those causes of hypertrophic facet joints, ligament tethering, may have been gradually building up over a number of years and are not painful until some incident occurs. They trip over the cat, they step down too hard off the stairs or the curb, and then they set up a little hematoma, and the whole vicious circle starts. You get the inflammation and the pain. Treated early by your physiotherapist can usually be reduced. But if it becomes more chronic, then you're going to find it difficult. And of course, my colleagues will then treat that by fusion to raise the disc height, to take away the movement. What we're trying to do here is to maintain the movement, improve that control of the segment by physiotherapy, and there's no need to fuse the level and thereby increase the stress risers of the levels above. So looked at another way, here is Madame la Guillotine sitting here. Here's the nerve coming out. Then we have the impacting facet joint here. So if that nerve is tethered to the facet joint, it's going to be held there and hit by the facet joint acting as a hammer. So that's if you have, and then if you have tethering between the nerve and the disc itself, the nerve can't escape. As the scarring matures, so it shortens, and it then brings this nerve, instead of coming out in its proper pathway, increasingly medially, diminishing something called the safe working zone, this triangle between the dura and the exiting nerve. And as it becomes more medialized, so it comes into the pathway of the nerve, of the facet joint, and becomes repetitively bruised. So nerve distortion by the underlying disc will be a cause of pain. Then we have the facet joint nerve tethering and impaction. So you've got this double whammy going on. The dorsal root ganglion becomes irritated, and we then make it worse by doing surgery nearby and adding to the overall scarring. So looked at another way, we've all been brought up to understand that a disc protrusion at that level will be causing irritation of that nerve, and that's where the problem is. Well, it isn't always as simple as that. The level below may be having impaction from the superior foraminal ligament, from the ascending facet joint, from small disc protrusions out in the foramen, and sometimes osteophytes sitting there. We call them shoulder osteophytes. And they sit in the front of the nerve. They're very difficult to see on the CT scan or MRI scan. But when you're in there and you mobilize the nerve, you can feel the little spike of bone sitting in the front of the nerve. Why it occurs, I don't really know. It's partly because the disc weakens particularly at the posterolateral angles, pulls on the bone at that level and produces very small osteophytes. And it may be aggravated by the effect of the facet joint beginning to push into that area via the nerve. And the whole lot may be augmented by the presence of a leaking disc or high-intensity zone. So let's look at this as a fairly typical example. Here is a patient who has memory pain. Memory pain. How many of your hip patients, your knee patients who have a successful hip or knee operation have memory pain? We have memory pain because we're not very good at diagnosing what's going on. And in fact, memory pain, I believe, is because we're missing an ongoing source of pain in the foramen, which is upsetting the dorsal root ganglion, which is why you then get this whole concept of neuroplasticity. Neuroplasticity only exists because there is a long-term, repetitive irritant stimulating the cells in the dorsal root ganglion. So this patient had memory pain, pain over the sacroiliac joint, and it had oodles of injections into the sacroiliac joint. But in fact, when we came to touch the patient, we were able to see that the pain was coming from both 4-5 and 5S1. And I don't know if you can see it, but the exiting nerve here is trapped and tethered to the upper pedicle at that superior foraminal ligament, and also tethered onto the disc. And this poor patient, in fact, had it at both levels. Here you can see the nerve tethered to the disc and tethered to the superior foraminal ligament. Sometimes we bump into things that oughtn't to be there. And this is the nerve sitting here. This lady showed or bred Great St. Bernard dogs, and you can guess that she was 4'8". So the dogs were taller than she was. So we removed that. We mobilized the nerve first, removed that a few days later, and she's still showing dogs at Crufts, now without pain. And that is a blue stained disc, and that little mouth there is a radial tear, and you'll sometimes see it on some MRI scan reports. I'm afraid many radiologists don't report it because they don't believe that the reader has any interest in them. The problem is that the radial tear may be kept open by the breakdown products and debris coming into that little tear. So when you come to treat it, you must remove that at the same time as removing the underlying breakdown products and causal agents. So here's another case. This is a diabetic with a pacemaker on warfarin, and you're going to see when that moves that it's fairly typical that we've lost disc height here and lost disc height here. Here's the nerve coming out at that level, and then that level, and then that level. And because these are hypomobile, that patient is hinging particularly at that level. So we're getting foraminal compression, and I don't know with this system if I can get it to do it again. the patient is hinging here and trapping and nipping at that level. So what did we do? There was no leak at that level, so we put in gel sticks, which is a polyacrylonitrile, which absorbs acids and slows down degeneration within the disc, and also serves by expansion to raise disc height. So if you like, it's going to cool that disc and help to preserve its function, because we're never going to really recreate function much here. At this level, there were a certain amount of symptoms, not the main severe symptoms, but they went into the territory of the presenting complex, and we decompressed that level. And at this level, where there were much more severe symptoms, not only did we carry out a full foraminoplasty, mobilizing the nerve root, opening up the doorway, removing all the scarring and the ligaments, but we then went into the disc and lasered that, and then shrank the back wall of that disc with the heat of the laser, called an annuloplasty. Now you can take the same concept in patients with spondylolytic spondylolisthesis. Instead of having to fuse that level, in an adult, they're not going to slip further. They've already adjusted, they've thickened all their ligaments, whoops, and the body has adapted to it, and usually what has happened is you've hardly got any disc left here, but you've got a very, very strong posterior disc wall, very thick, and you don't really want to disturb that too much. And then by taking off the bone of the healed fracture site off the nerve and mobilizing the descending S1 at that level, you can treat the patient without the need for fusion. And that we published many years ago. So for the last 20-odd years, we've been doing predominantly single-level foraminoplasty, because that's all we could do with the technology available. And we have been improving that, and we're now into doing combination foraminoplasty. Here's another case. Here at this level, the patient had a leaking disc. There's the nerve coming out. There's the dehydrated black disc. That was treated with a laser discectomy and shrinking the back wall. Then at this level, I don't know if you can see on the screen, but can you see the white area in the back wall of the disc? That's a high-intensity zone, and the breakdown products are causing a lot of scarring and irritation, which you can see here in the foramen. So that level was dealt with a full foraminoplasty. And this one, the nerve was tethered to the disc, so sorry, it sounds like a royal we, it's a big team in theatre, isn't it? So we all carried out a foraminoplasty to mobilize the nerve, but didn't need to damage the situation further by taking out disc, but we put gel sticks in there as well. So there are lots of different combinations that we can do. When you're thinking, well, what's this really going to do to my practice? Well, for us, the philosophy is different. We need to find the source of the pain and then just remove the causal agents as minimally as possible. And we can apply that to protrusions and extrusions and sequestra, because we can go into the epidural space, find the sequestra, and take it out through the side door. With spondylolisthesis, we can open up the doorway, take the pressure of the bone and the spikes and the ligaments off the exiting nerve root, and treat foraminal foraminal stenosis in the same way. You will bump into axial stenosis or canal stenosis. Well, a lot of those patients, the canal stenosis, for the most part, is a combination of facet joint hypertrophy and disc protrusion and ligamentum flavum infolding from the back. So you get this triple concertinary or constriction of the epidural space. If you just remove the disc protrusion, you can make quite a considerable difference to that volume, especially if you play around with things like pi r squared. You'll see a very small difference in that anterior wall dimension will make a huge difference to the axial volume. The other thing to bear in mind in many of these patients who are getting fairly elderly is that their body has again adjusted. The nerves have adjusted to being progressively constricted. So if you can give them a small amount of axial increment, then they will do quite well. So then there's failed back surgery. So patients who've had a failed microdiscectomy, everybody's very reluctant to go in again and do anything about it. But you have to ask why the discectomy has failed. Okay, the recurrence rate for disc protrusions in microdiscectomy ranges in the papers between 3 and, I'm afraid, 13%. If you've got a sizable recurrence, you can go back in through the side door, go into the side of the disc, take out the disc protrusion and get out through the side door without having to traverse the epidural space and all the scarring that will be there. In cases where you've had, say, a failed fusion, you'd think, gosh, there's nothing else you can do there, but there is, because why has the fusion failed? It's failed because either the nerves have retethered subsequent to the fusion or the total disc replacement, or they were never released in the first place. So by walking up the nerve and looking and seeing what's going on, the patient will tell you on the table whether you've done something to relieve their condition. Of course, in some cases, the most difficult of these are those where there's a cage that's slightly misplaced, or a total disc replacement or caging, intervertebral caging that's been done through the anterior approach, where disc material has been left behind the cage and is therefore protruding. So you have to be very careful how you chamfer off that protrusion without exposing the disc replacement or cage. Then again, high intensity zones we can treat by going into the disc and lasering. Now, I used to have lots of arguments with my colleagues about laser disc decompression, and the concept was that 1250 joules of laser energy put into the disc would reduce the pressure inside the disc by 50%. And I used to say, well, no, I don't believe that, because the moment the patient stands up, the pressure's back. But patients got better. Not all of them, and it's only really on its own useful for broad-based disc protrusions in disc heights of 4 millimeters or more. But patients do get better from that, and I think there's actually more than one thing going on. I think one of the things that happens is, A, you're going to reduce the bulk of breakdown products being produced. The second is that you'll shrink the posterior wall so you won't have so much compression directly onto the nerve. But something else, you're probably very aware of papers coming out from Denmark talking about Propionibacter and treating back pain with antibiotics. And they have claimed some very good results. I've tried using it in my practice too, not in many patients, but I found the patients very, very difficult to tolerate the antibiotic regimen, first of all, and I'm still not quite sure that I've got anybody better that way. But the jury's out. But laser discectomy sterilizes the inside of those discs. So maybe that's why laser discectomies have been useful for all these years. And there are hundreds of thousands of patients now around the world who've had laser discectomies. And finally, of course, patients who have adult scoliosis, very few of them are progressing. I've only seen one progress over this period of time. But if you again go for the source of the pain, you can treat that without them having to have an aggressive fusion or be, I'm afraid, sent on just for chronic pain management and a really degraded retirement life. And the treatments that we have in hand are the full foraminoplasty or endoscopic intradiscal discectomy or laser discectomy and gel sticks at adjacent levels, or combinations of all 3 or 4 techniques. Well, is it any good? Well, first of all, you've got to look at the papers and the outcome criteria that they use. A lot of centers, especially in America, use the McNabb outcome, which is very soft. A lot of centers over here use the Oswestry Disability Index, which is good, and then there's the Rowland-Morris score as well. But nobody really has defined what is success. They look at a 10 or 20% difference, or they look at the improvement in leg pain after microdiscectomy or back pain after fusion, but seldom do they report on the combinations. So we asked 150 of our patients in the Spinal Foundation, have we really helped you? And they came back to us and really taught us to look at this in 3 zones: the back, the buttocks and thigh and groin as another level, and symptoms below the knee. If we cleared their symptoms, of course, that was an excellent result. But they only told us that we had had a good effect on them if we had at least halved their back pain, halved their leg pain, and halved their below knee pain. So that was our definition, which we took from them. Satisfactory meant we could achieve that in at least 2 of those zones, and poor was if we didn't meet the 50% barrier in any one of those levels, and worse if they were obviously made worse. So looking at our single level treatment for foraminoplasties, we've been reporting on that for some time now, and our experience is that in earlier days, 70% of my patients were failed back surgery. Because I was doing something off the wall, I wasn't getting nice virginal backs. I was getting much more difficult cases. The great advantage of the technique is it's transaegist, and because we're operating on the patients under sedation, the comorbidities are less relevant. And our first papers have shown that the success rate, as defined as excellent or good, was achieved in 80% of patients at 2 to 4 years. We've just published now our 10-year result. It's all been peer-reviewed, and we have a 72% success rate at 10 years and no destabilization of the spine. And therefore, one may say that this technique offers you quite good prophylactic protection for your patients. In terms of complications, it's 3 times less prone to complications than microdiscectomy, 7 times less prone than fusion. But more importantly, it's an order less severe. And for instance, in the first 958 cases, which included my development curve, my learning curve, we had 8 recurrent protrusions. In a current audit, now of 4,350 foraminoplasties that I've done, and 3,500 plus laser discectomies, we've had 9 infections and 7 dural tears. Very sadly, we had 2 last Christmas, but which ruined the figures. But the return to work, we tend to hold the patients back a little bit and limit that to 4 to 6 weeks, because we're working through a very small hole. And if they tend to overdo their activity levels too soon, they will make that nerve swell. You saw how red it was. It's very prone to expand and swell in a tiny hole, and they'll get a recurrence of their symptoms. And it can be very disabling. So we tend to artificially hold them back. And in terms of combination therapy, which is now what we're expanding up to do, we would do at the prime level for pain production, a full foraminoplasty. Then at the next level, we would do more of an endoscopic foraminotomy, just with a much lesser extensive procedure. And at the third level, a laser discectomy or annuloplasty. And at the 4th level, perhaps insert gel sticks. So we're now able to treat really some quite horrendous spines. And in terms of outcome, we've just done a survey of those over the last 2 years in 80 patients. And you'll see that it's various combinations of foraminotomy, foraminoplasty, and laser discectomy. And in this catchment group, 40% had failed back surgery. The age range was 46 to 89. There were no DVTs or the standard complications. And 20 out of that 80 were completely pain-free, despite multi-level interventions here. 33 had a good result, so all their pain was at least halved. And then there were 24 who were satisfactory. We hadn't quite got it in all 3 levels. And there were 3 which were poor, but none that we found were worse. So in summary, with regard to endoscopic minimally invasive spine surgery, I think you can recommend foraminoplasty. Please bear in mind it's not foraminotomy. It's not just going in there making a big hole. It's going there making a very discrete hole and mobilizing the nerve as safely as possible. It seems to give at least 10-year quite good results, and it can be used for failed back surgeries. It would be much better if we could get to the patients first and be the filter to reduce the amount of open surgery. We've already gone over the applications for this surgery, and importantly, it's very useful for the aged and infirm. It's also a vehicle, I believe, for stem cell disc replacement, which is what we've been working on now for some 12 years.